And we'll give it just a minute as people file into the webinar. And as you file in, hopefully you can see on our screen is a picture of our web page with the address at the top. And I'll be explaining in a moment. That's where we're updating the events and the speakers and other interesting things. There's a good number of us in our virtual room today, so why don't I go ahead and get started with things. I'm Joe Walther, one of the co-organizers, along with Ambuj Singh, and we welcome you to the second session of our seminar series on issues, approaches, and consequences of the COVID-19 virus. I just want to say a few words of orientation before we start with today's speaker. As I was saying, as some of us filtered in, what you see in front of you now, hopefully, is just a little snapshot of our web page, and the URL for that page is in bold across the top. And that's where we invite people to go to look for updates and for additional links as they become available. And we'll be continuing to update that as our work in progress develops. I wanted to show you a couple of aspects of things that are on this website that might be of particular use for you. One is that we do have a place where people can sign up to get updates by email. I'm going to enlarge this a little bit so you know what to look for. In the middle of that home page is a place where, as I said, you can click a link. It'll take you to a Google group where we invite you to enter your email address so that we can send you the announcements of upcoming speakers and other information related to the series. Now, going back to our homepage again, this arrow is showing you where we now have links to each of the speakers, today's speaker and last week's speaker. Those links are clickable, and if you follow those, it'll take you to the nature of the talk, the speakers, and we now have the capacity for sharing the recordings of our talks. Those are online in YouTube. So here's a link you can click that asks you to click here to watch a recording of this webinar session. And if you click that, it'll take you straight to YouTube, and you'll be able to watch what we discussed last week, and we'll try to keep updating that as we go along. That's all our introductory comments. I'm turning it over to Ambuj Singh as we celebrate his birthday and move on with our colloquium series today. Ambuj?
Thank you, Joe. It's a pleasure to introduce our speaker of the day, my colleague and a good friend, Professor Francesco Bollo. He is in the mechanical engineering department at UCSB. He is also affiliated with the ECE and the CS departments and the CCDC. Despite him being in the engineering college, I think he is a mathematician by heart, as you will find out during his talk today. He has studied the dynamics and control of natural and engineering and engineered systems, including bird flocks, school of fish, human engineered systems such as robotics, infrastructure, and he has also studied here social systems. And as it turns out, the talk that he'll be giving is about control of both the human elements and the virus. So it's a mixture of natural and social systems. And he will discuss models that explain the behavior of such systems. So I'd like to remind you of a few things. One, questions and answers, we can ask them in the panel, in the chat panel. If you can ask those questions, I will, at the end of the talk, I'll answer those questions and answers with the help of Francesco. I'll pass them to him to answer. Second is for the students that are enrolled in this seminar, we will have some amount of time after the talk. So if you can log in into that other Zoom link, so we'll have a time to discuss your questions at length with Professor Bollo. And just in terms of a highlight of what will be happening next, we will be in the next meeting, we'll talk about the aspects of data. How do we collect data to study these systems? Then we'll have a seminar on the economic aspects of the disease, and then we'll follow that with the social impacts of the disease. So that is the sequence of talks going forward. Without much further ado, I would like to welcome Professor Francesco Bollo. Thank you.
Thank you all. Good afternoon. Thank you, Joe. Thank you, Amuj, for the very kind invitation. Allow me to get set and begin. I'm so thankful to have a chance to talk to you all today. And so hopefully you're all able to see my slides at this time. So I'm delighted to be today here to talk to you about models. And to do that, before I do that, allow me to please acknowledge the terrible impact of this pandemic and all the suffering that it has caused, and all the complex, dangerous, and critical work that has been taking place all over the world by our healthcare professionals and by frontline workers. And so we owe them all a great deal of gratitude. And I think if you haven't had a chance to listen to last week's webinar, I think by Dr. Gonzalez and Dr. Fitzgibbons from Cottage Health and UCSB respectively, I would encourage you to watch it later. Similarly, a wonderful video on the New York Times website listed here. So these slides will be available in a number of ways, including my website, for example. Why are we talking about today models? Why are we? It's quite a remarkable moment in time. In my experience, it is really not very common. Do you read an article where on Science Magazine, on the New York Times, on the top venues in the US and in the world, about how mathematical models are having a major impact on matters of life and death? So this is a unique moment in time, and it's a rather surprising that mathematical models take this unprecedented position. So this is an article from Science, March 27th, which talks about the March 16th report put out by a group of scientists at Imperial College. And that particular article, which we'll review later, ended up having a major, apparently, a major impact in the decision-making process of the British and of the American governments. So that's the motivation why we're here. Allow me to tell you about my outline. So I'll give you some historical notes on, not on the history of epidemics, but on the history of mathematical epidemiology. And after that, I will review, let the history lead into some mathematical modeling. And then from that to current models in the literature, including both stochastic models as well as direct statistical models. I'll finally compare an evaluation and conclude with some notes on non-pharmaceutical interventions, which is a fancy way of saying that we're all locked at home and we're supposed to wash our hands and so forth. So non-pharmaceutical interventions is what we're all adopting to stop the diffusion of this outbreak. Before I continue, let me clarify, this is a very elementary introduction. It is my purpose to provide simple ideas with which you may be able to read articles in the news and understand them better. I will not propose my own model, and I will not propose my own predictions as to what will be happening. There are people with better access to data and more qualified than I am to do that. So once again, I'll just give you some language and some concepts on how to read and understand these concepts and models, which are dominating our literature right now. So let me start with the first event in history recorded of mathematical epidemiology. In 1760, one of the members of the famous Bernoulli family, Daniel Bernoulli, wrote about smallpox. So smallpox is an incredibly terrible disease that has killed the largest number of human individuals in history, allegedly. No region of the world, no class, gender, no kind of geographic limitation knew. This was known by this virus. Egyptian pharaohs, Roman emperors, Chinese, Japanese emperors, kings of France and Spain, all the way to American generals during the Civil War, died of smallpox. So in 1960, there was a controversy, and the controversy had to do with variolation. So at that time, the only available prevention mechanism was inoculation with a mild strain of smallpox, something that wasn't as virulent and as dangerous. And so the controversy was, would you like to have the long-term benefit of being immune to smallpox, or would you like to incur, versus the risk of incurring immediate death? And so by using a mild strain, so percentage-wise, it was something along the lines of 1% death rate at birth if you were to be inoculated versus a 15% estimated death risk if you ever were to get this disease at any point of your life. And so in this paper that appeared in the French Academy of Science in 1760, Bernoulli performed a mathematical analysis that showed that you should inoculate yourself. That if you were to do it at birth, then your life expectancy would increase up to 3 years. This was very controversial, of course. But the key part of this entire slide I wish to emphasize is that the entire mathematical analysis was based at the beginning of it upon some empirical data, some estimates of all of the relevant quantities. So that's the key idea from the 1760 paper that I want to mention. And as it turns out, this idea is the same that I will mention at the end of this talk a few minutes from now. So fast forward 150 years, Hamer published a paper in the Lancet in which he introduced the concept of compartments. Each individual is to be classified as though that individual is susceptible, infected, or recovered class, possibly including people who have disease caused by the virus. And moreover, he introduced the concept that the incidence, which is the rate of new cases per unit time, how quickly does the virus spread, it's due to the product of the density S and I. So you will see this in the formulas I'll show later. And these nonlinearities are the ones that create this phenomenon of an epidemic outbreak, as we will talk about. A major breakthrough took place in 1927, where Kermack and McKendrick introduced the concept of a threshold, and we will see that in simulations. And basically, this paper explains how there is a critical value above which there is an epidemic outbreak. By outbreak here, I literally mean to say an exponential explosion in the number of infected individuals. And they started in earnest the use of differential equations to model this. Okay? So this appeared in the English Royal Academy. So what I'll present today is much of the mathematics I found in a nice survey by Dr. Heathcote in 2000. This is a leading survey. And as we continue, I wish to mention that there isn't one model of epidemic population in the literature, but rather, exactly using the language of Heathcote, there is 1001 models. So it really is a rich literature, as in the Arabic novel by that name. And in all of these models, it's interesting to understand how the threshold determines the outbreak. So in case you are able to download the slides later and you're interested here, I have reported the DOI numbers, but these are live links. You can download the papers and follow up. So let me now turn to the actual mathematics after this brief introduction. So compartmental models. So as we were saying, one of the early ideas by Hamer in 1906 was the concept of using blocks such as this, block diagrams such as this. So the idea is that at the beginning, perhaps you and I are susceptible individuals. There is a transition, we become infected, and then there's hopefully later on a transition, we will recover from the virus in a positive way, hopefully, and we belong to the recovered category. If we have developed immunity, then there is no arrow all the way back, right? So that's not the case, hopefully, for the current epidemic. There are therefore here in this diagram two types of transitions. One is from S to I, from the susceptible to the infected, and one from the infected to the recovered. Now the second transition is spontaneous. It does not depend upon, your recovery does not depend upon the number of susceptible or the number of infected individuals. Instead, the first transition is very much critical and it depends upon the product of the quantity here times the quantity there, as you will see in a second. So compartmental models are models whereby you see the population classified in groups like this. There are very low complexity models, such as this one that I'm showing here. There's medium complexity models where you imagine there's actually here, there's birth and death, there's vaccination, there's maybe loss of immunity as time progresses, and there's all the way to highly elaborate models which are composed of a large number of compartments. This is a model coming from scientists in Italy, where each possible state of the patient is classified. I will explain in a minute what the meaning of this symbol on the edges is. For now, I just want to mention this is a highly, as compartmental model goes, this is relatively complex. So now, how do we understand the evolution of the epidemic on these compartmental models, right? Well, we need to write some formulas to describe the flow of individuals from one compartment to the next. If I and I'll write equations for just a couple of slides and then I'll come back out and I'll draw some consequences. So hopefully I am not too abstract here. Let's use the symbol S to denote the fraction. It's the fraction of the population that is susceptible, X the fraction of the population that is infected, and R the fraction that is recovered. So we're really worried in keeping X small. Now, the fact that these two transitions are substantially different, this one is spontaneous, the second one, whereas the first one is one that requires the interaction of individuals from the previous compartment. These two facts imply different formulas for these flows of individuals. So in the second and simpler case, there is a rate parameter, gamma. It's the fraction of individuals that will become recovered per unit time will just depend upon the number of individuals in the compartment X. Whereas the flow that goes from the first to the second depends upon the product, right? Just as I mentioned earlier. And it's modulated by a parameter beta, infection rate. So if you write down a set of equations to explain what is happening, so here, what is a differential equation? I don't wish to assume everybody knows what that is, and I will get away from this very quickly, but this is perhaps the most basic fundamental mechanism that allows you to study systems that evolve, where variables evolve with time. If you have the motion of a car, the evolution of seasons, any quantity in physics, science, or technology that changes with time, that may very well be described by an ordinary differential equation as we now see here. And so these, strictly speaking, those there are the equations. But in order to define them, as I said, I need to introduce two parameters, the infection rate and the recovery rate. This is these parameters I will elaborate more in a second. And in order to uniquely determine the evolution, I need to know at time zero, so these symbols mean S, X, and R at their initial values. And once I know their initial values in the parameter, then what this equation is saying is describing to me the rate of change, how much does S change. And as we were seeing from discussion earlier, the key intuition here is that the second equation here, the amount by which X changes is proportional to both a growth due to the infection, meeting between susceptible and infected, and then the recovery effect. One is positive and one is negative, and you will see how these two mechanisms will trade off with each other. So let me give you a little more detailed explanation of the mechanism. So, and the reason I give this explanation is also because this will implicitly explain why this model is limited, and despite that, why it's also such a relatively good model. So imagine I have a population of individuals with some frequency, with a contact rate, these individuals will meet. And so this meeting rate, beta sub c, this is a contact rate, this contact rate, beta sub c, is informing me that on average, each individual will meet beta sub c times delta t individuals over a period of time delta t. So I will have a question for you. Just take a second, think among yourself. How many persons would you meet on any given day? How many persons, or more accurately, more precisely, how many new persons would you meet today that you haven't met in the last few days? What's that number? Is it 0 because you're locked at home, or is it 5, 10, 20 when you go about your normal life? Well, that number describes the contact rate. There is another parameter, which is the transmission fraction. That is to say, when you meet these persons, how many times, imagine you are infected, how many times will you infect them? Is that 50%? Do you hang out very close to each other? Do you have a chance to sneeze or cough or exchange, shake hands? So that's a transmission fraction. That's always between 0 and 1. It tells you how likely is that that contact results in an infection. So now the third parameter is the recovery rate, gamma. And so what that means is that essentially if you're infected, how many days does it take on average for you to recover? In other words, to get over the infection. Now this may mean many things. It may mean, for example, you don't show any symptoms and you fully recover, or you arrive at the hospital and you're isolated, or more drastic outcomes at the end of which you are not in the population any longer. So the infected period is the duration of time during which you are possibly meeting other people and infecting them. And that it's 1 over gamma. It's the inverse of the rate of recovery. So as I was writing in the previous slides, the incidence of the epidemics, which is how much is the infection density fraction tomorrow compared with today, what's the change? That has a positive and a negative term. The recovery is simple. It's just, it's easy to estimate gamma as well, relatively easy, perhaps. But it's definitely interesting to look at the positive term. The positive term, as you remember, I mentioned Hamer had this term that he introduced that realized that this was due to the product. And the parameter that is also very important, the other single parameter, is you multiply together contact rate with transmission fraction. There's a scaling term there, and you obtain a rate of infection beta. So let me simulate this for you. Let me show you what a computer will tell you would happen if we were to implement this set of equations, so these 3 equations. So on the left is the case where the virus is a very benign virus, and despite the fact that it is present at the beginning in a large fraction of the population, this is a virus that dies off very, very quickly. And that's an entirely possible outcome given this set of equations, depending upon the 2 parameters, beta and gamma. So this is a case where there is no epidemic outbreak, meaning to say there is no exponential growth, there is only exponential decrease. Now, instead, on this other plot on the right, I'm afraid some viruses are described by parameters whereby you have exponential growth for small time. So that's the rapid growth you see here at the beginning of the plot. Now, this plot is over percentages, so it's not possible to obtain exponential growth forever. Instead, what happens is that there is a peak time predicted by the model. And after this peak time, there is a slow decrease. In this particular execution, it just so happens to be the case. So this red curve is the curve of infected individuals. I'm also plotting the susceptible individuals, which is essentially, I'm assuming the entire population. So at time 0, 100% of susceptible individuals are present in the population. Unfortunately, for such an aggressive virus, essentially everybody would get the virus. R is the fraction of people who have recovered. And so sometimes we're on the left, sometimes we're on the right. What does that depend upon? It depends upon this parameter. So the growth in X occurs when that parameter, when this parameter here is positive. So the question is, when is beta over gamma times S greater than 1 or not? So this is called, in the literature, this is referred to as the epidemic, as the basic reproduction number, R naught. So the R naught can be understood to be the expected number of secondary cases produced by a typically infected individual. So there is, you are infected, and the question is, how many people on average do you get to infect before you are in the recovered state? May that mean to say you are completely isolated, you have passed away, or you are recovered, you've developed immunity from the infection. So now, let's review what that parameter is. As I was showing you earlier in the previous slide, R naught is equal to the product between beta, the infection rate, 1 over the recovery rate, and the number of individuals in the population at the beginning of the epidemic. And so when you work that out, that's equal to, so beta was, let's remember, the number of contacts per day that you have times the likelihood of transmission within those contacts. And then you need to multiply that by the number of days you're infected and in the middle of the population. And this final number here, maybe we'll not worry about it right now. Perhaps we will assume that at the beginning of the epidemic, that's 100%, which is 1. So now when R naught is greater than 1, you do have, unfortunately, exponential growth. And so this is the picture I showed to you earlier. So this is the case where R naught is greater than 1, right? And let me show you in more detail just that plot. What happens is the following. As I was saying, there is a moment where the epidemic reaches a peak. In this particular simulation, this is day number 4, essentially. And it's certainly true that before day 4, the reproduction number is is greater than 1. At the peak day, the reproduction number reaches exactly 1. And then after the peak day, the reproduction number is less than 1, and the number of infected individuals is decreasing. I wish to mention that, sometimes you read the literature, maybe the popular press, and people talk about making sure the reproduction number is less than 1. Even if we get to the point where the reproduction number is 1 and then below, that still doesn't mean the epidemic is over. There's still plenty of individuals who will get infected after the reproduction number has become less than 1. Now, so I'm done with equations. I apologize. I hope you haven't lost me. This was one of the key ideas here, is the fact that the reproduction number is contacts per day times the transmission fraction times the number of infected days. And at the beginning of the epidemic, everybody is well, depending upon the virus, but everybody is susceptible. So now, let me just try to tell you what these numbers would be for COVID-19. For COVID-19. So so all of the numbers here that I'm presenting on the slides are numbers that refer to the epidemic outbreak before social distancing was put in place, before other non-pharmaceutical interventions were put in place, before fear would be diffused among all of us and would would affect our behaviors. So this is at the very beginning, before any intervention. So now R0 here is reported to be anywhere between 2.2 and 2.7, therefore larger than 1. So the unit of measure is persons, so 2.2, 2.7 new individuals that you will infect if you are infected on average. And however, it's important to explain this is highly dependent upon region, about age group, and so forth, social behavior and so forth. It's also important to say some estimates are much higher at this moment in time. What's the incubation period? That's the moment of time, the duration between exposure and first symptoms, cut a long story short. And it could be 5 days, but it could also be much longer, say up to 12 days, according to recent studies. For the model, I don't want the incubation period. I need the infective period. What I mean by that is the duration of time that a person would be walking around town and maybe unwillingly, unknowingly, be infective and infect other individuals. And as I said, that can happen because of a number of reasons. Perhaps you have very mild or no symptoms. Perhaps you have symptoms, you get tested, but you don't have the result of the test, and so on and so forth. And so for the purpose of what follows, without really very many, I really don't have any good reason to say this. So this is really just my own guess in order to perform some simulation in what follows. Let's imagine that that's equal to 5 days. Another interesting number, which is the doubling time. So after how many days does a small number of infected individuals double? And some reports inform us that number could be anywhere between 2 to 7 days. So this epidemic is doubling rather quickly. So now, allow me to play with this for a minute. And as I was mentioning earlier, our R naught, the R naught of COVID-19, should be computed according to this extremely simple SIR model by multiplying the contacts of that people have per day, the transmission efficiency or factor, and the number of infected days, right? So here you would get 2.5, which is a number in the middle of that range, 2.2 to 2.7, if you were, for example, to assume that the full population is susceptible, that the infective days, the period of infection that during which you can infect other people is 5 days, and then maybe you assume that you meet 2 new persons per day that you haven't met in previous days, and maybe there is a transmission fraction efficiency of 25%. Now, the word efficiency, I apologize, is jargon from engineering. The transmission is highly undesirable, but in any case, you know what I mean. So if this is one way in which this very simple arithmetic can be made to work out, but of course you can understand, I can increase this number, decrease that number, increase that one, decrease that one. There's plenty of ways in which this total R0 ends up being 2.5. Or vice versa, if there is uncertainty on any of these parameters, then there will have to be uncertainty in computing R0. So now let me do other calculations. These numbers that I here, kind of, really guessed for our thought experiment are if you combine them together, you get a doubling time of 2.3 days. And finally, if you combine this number, there is a concept in the literature which has a very weird and I would say unfortunate name, and that is the concept of herd immunity. So what does herd immunity mean? The question is, what percentage of the population needs to have developed immunity in order to reach the situation where the reproduction number is equal to 1? So now notice that here I've changed my symbol. This is R0. I need to say at time 0. Here I need to say at time t. And the reason I say time t is because at time 0 we assumed S at 0 was 1. But now with time, as a fraction of the population gets infected, the number of, and then later recovers, the number of susceptible individuals is only but decreasing. And so now, whereas R0 was greater than 1, I now multiply that by a number less than 1. And so I have a hope that this product, called the reproduction number at time t, will be finally equal to 1 and then lower. And to do this calculation is very simple. It's just the fraction of infected at time t is, in any case, do simple calculation you obtain, you need to subtract 1 from 1 minus R0, and that's 60%. So this is saying that if you have an epidemic, you have a virus that has an R0 of 2.5, and if the entire population is susceptible, then you need to wait until 60% of the population has been infected in order for the reproduction number to drop to 1. So that's a very large number. And of course, if you then multiply by the fraction of people who are going to display symptoms, the fraction of those who are going to require hospitalization, and then the fraction of those who are going to unfortunately pass away, that's a really terrifically high number in a country like the United States, 330 million people. So now, what I've shown to you is a very simple model. It's called the simplest SIR model. And I have much more ground that I would like to cover. So let me move on and talk to you about how do I make these simulations more realistic? How do I do that? Because the model I've shown to you has a couple of problems, and well, has one fundamental problem. It's very homogeneous. Instead, the world is heterogeneous. It's heterogeneous by spatial positions, and it's heterogeneous by age structure. And so there are two approaches that I would like to discuss with you. One is, well, for example, let's think about spatial structure. This is a graph that describes how, in reality, it's not reasonable that an individual that lives, in a given location will be equally likely to meet and mix with an individual who is far away. And so not only spatial position, but also age and social behavior are very important in trying to determine the rate at which person-to-persons meet. And so one approach to do that, which is very similar to the equations that I've shown to you earlier, is still that of going from an ordinary differential equation like the one I've shown earlier, where there is the quadratic nonlinearity by Hamer, to an equation which is really very, very similar. It's essentially the same equation at each location I in the graph. And the graph, how do you construct the graph? You could group people by spatial position, by age, and by social behavior. So this model is sometimes called the multi-group model. And still is the same nonlinearity, and still you will see the existence of the same threshold number giving rise to an epidemic outbreak. Now, this model is very easy to write, and also it lends itself to nice simulation and understanding. However, you now have to estimate the contact rate for individual I or groups, individuals that are in group I and individuals who are in group J. So you now have an entire large number of rates that you need to estimate. And so that becomes a harder task, of course. One way to perform this estimation, or actually one way to avoid that estimation altogether, is to go from deterministic to stochastic models. These models are really very much in the same spirit of the simplest SIR model that I've shown to you, right? It's in the same spirit. It's still models with compartments, and still it's the contact that generates infection. However, instead of explicitly computing and estimating contact rates, you generate a synthetic virtual world, and then you stochastically simulate it. So let me talk to you now about that March 16th report, right? In that report, the scientists generated a population of synthetic individuals on their computers, assigning spatial position, age, and social behavior to all of them. They imagined that contacts would occur at any one of three possible locations: at home, at some kind of central hubs, work, schools, markets, and churches, or finally, simply in a local neighborhood. The parameters of these person-to-person contacts in any one of these three locations were based on a large data set that would allow you to tune, to calibrate the parameters of your model. And then they ran simulations, large-scale simulations on high-performance computing clusters. People refer to this as Monte Carlo simulations. And for those of you who have time, there is an illustration what such a simulation would look like at that particular YouTube video. So here, this is akin to that old video game called SimCity, for those of you who are familiar with it. You are basically building a virtual world and imagining people are meeting. This is the link to that particular March 16th report, which has already made history in the sense that it already impacts the decision-making in leading governments in the world. That's one approach. So this Imperial College model is still very much in the spirit and in the tradition of SIR compartmental models for mathematical epidemiology. But there is also a second, or maybe perhaps third, depending upon how you count, approach, which is based on direct statistical estimation. And this is an approach in which you actually do not impose any mechanism for the transmission. You do not model micro interaction and micro transition. Rather, you work directly with the signals, and you model, you do interpolation of the signals, right? And you model, empirically observe curves. You see a curve that is growing at linear, exponential, or polynomial rate. You see a curve that has a maximum, and then it starts to drop, and you estimate based on that. Now, this is, for example, the approach taken in the work by the Institute for Health Metrics and Evaluation, IHME, led by Dr. Christopher Murray. And it's in a paper that was published in medRxiv, which is another site online where preprints are published. This occurred exactly 2 weeks after the Imperial College report, and it happened on March 30th. So the approach here is rather different. This is also very much data-driven, of course. Information is collected about death curves per day, age-specific, the start date when non-pharmaceutical interventions were imposed, data about hospital beds, ICU capacity, and so on and so forth. And starting April 17th, so after that, the website that I have a link to later also incorporates information about mobile phone data. So how do they compute their predictions? Well, you need to take data from one city, say Wuhan, and then try to apply it to a different city, say Santa Barbara. And so you would do some standardization based on age structure. That's a standard method in demographic analysis. You then look at a large number, instead of doing it by country, you do it by, at a certain geographic resolution. And so, a county in Santa Barbara or a region in Italy would be an admin 1 location. And you select only those locations where the death rate has reached a certain threshold. And when you select them, you time reference them, meaning to say you start the clock at each location based on the day when 0.3 deaths per million were reached. And then you do curve fitting. And so, for example, you use a Gaussian error function to describe your cumulative death rates. And you optimize the parameters of the Gaussian function. And then importantly, you have to have a covariant or a control variable. You have to have a way of informing your statistical regression that the process was obeying a certain rule up until the day when the MPI were imposed. And then after that, of course, there is a different effect that needs to be taken into account. And this covariant was estimated from the Wuhan data by using the data before and after the MPI were imposed. Wonderful. So for those of you who are interested in following up, this is the website where you can see the current estimates based on this direct statistical model. And this is a cut and paste from the website earlier today for the state of California. And it's a very informative website. So I can certainly say that you can follow day by day updated estimates based on this direct statistical model. Okay, so before I continue, let me mention there is a broad range of models in the literature. So I talked to you about the Imperial College report that appeared on March 16th. It's based on SIR models, but here I have 2 other important models that have appeared. And I would say the literature, well, web servers and journals are being flooded right now with all sorts of variations of these basic ideas. As I said, in the words of Heathcote, 1,001 models that probably appeared since January 1st, 2020, as well as there are a large number of models that are using statistical methods, direct estimation without assuming any SIR mechanisms. And I mentioned the one by the University of Washington, the IHME model, but there's another one here by some Italian scientists as well. And there are live links to all of them. Now, let me talk just briefly about how would I summarize and evaluate these models. So, interestingly, on the March 30th report by the the IHME on medRxiv, some criticism is levied towards the SIR model. It's very carefully worded and very qualified, but I thought it was interesting for me to mention it. And the criticism is that SIR models require random mixing between all individuals in a given population. And it's certainly true that the simplest model I used, the basic simplest, with the one that I've shown to you at the beginning, suffers from that particular limitation. But I believe that that might perhaps not be applicable to all SIR models. Certainly, if one were to use current estimates that were not before the MPIs were imposed, SIR models would generally over-predict. By this I mean to say predictions larger than what actually end up being occurring. But let me jump to 4 here before I go back to 3. And so here, the report says assumptions of random mixing can overestimate, of course, the growth of the epidemics by not taking into account behavioral change and government-mandated action, right, as I was saying. So certainly you need to be very careful when you read models to understand if they are calibrated on parameters before the non-pharmaceutical and before the behavioral changes or after. Finally, the criticism levied by one set of models to the others is that the results of the models are sensitive to starting assumptions and essentially also data. Interestingly, this was March 30th. On April 9th, right, 9 or 10 days later, there was a CNN article whereby various scientists from the UK were interviewed and asked to comment. And the article is predicated on the following data. The data is that as of April 9th, the AHME website was predicting in the order of 67,000 deaths in the UK, whereas the Imperial College model was predicting fewer. So now this is actually in opposition, the exact opposite of what I stated in the previous slide. Of course, this was the prediction by the Imperial College if MPIs were imposed. And so this is some language from a scientist at Cambridge University describing potential drawbacks of the IHME model. And essentially, if you read these complaints, are very similar to the other ones in the previous slide, ironically. So very strong assumptions are made about the way the epidemics will progress. And of course, we are doing, curve interpolation well, let me just jump to the third one. And methods like this, which are, statistical models, are well known for being extremely sensitive as new information comes in. So the reality is that both groups are commenting on the sensitivity of these models upon assumptions and data. What I was saying at the beginning of this talk was in the work by Daniel Bernoulli in 1760, the entire predictions about what you should do in the face of smallpox were entirely dependent upon the data that he was given. This article can be read by you at that site. So I should say, it's actually not accurate to say that the Imperial College model was predicting very, very small number. This is a cut and paste from the Imperial College report. And at that time, and still now perhaps, it's not completely clear what the reproduction number is, whether it is 2 or 2.6. And you should understand this is a terribly long and complicated table to read, but essentially we don't know exactly the influence of all of the data on what the final number of deaths here. And so here it is certainly true that if sometimes the model predicts in the order of 20,000 deaths, but other time the model predicts in the order of 48,000 deaths. Okay, so let me give you a summary of what I have done so far. I have given you a very brief review of 260 years of mathematical journey studying mathematical epidemiology. I do believe, as the mathematics course, the results have been stellar in building up these basic models. For example, the simplest SIR model, which explains really nicely emerging behavior, emerging phenomena. So what happens, unfortunately, as these person-to-person interactions take place. And the salient features I tried to describe to you are due to the reproduction number, the growth decay phenomena in the epidemics. It first grows and then it drops as we drop the peak time when the reproduction number becomes equal to 1. And also these models are very good. They really do explain the non-pharmaceutical interventions. I'll have more words to say in a minute about that. Now, the simple model, I would argue, is very useful to build a good understanding of what could be happening, of the mechanism. If you do want to have realistic predictions, as realistic as possible, despite the fact that the data is rapidly changing and there's lots of uncertainty, then I have reviewed two approaches, one based on still using multi-group SIR model, structured, so you try to group people by age, by geography, by social behavior, and you run stochastic simulations of them, large scale on large computers. Or you avoid altogether the assumption of the SIR understanding, and you go straight for statistical models that are based on data fitting, and you estimate what will happen tomorrow based on everything that happened until today on every other country in the world. Here's another summary way of trying to explain to you what is the purpose and the scope. Really, I believe these models have different scopes ultimately. The simplest SIR provides you with a low complexity explanation and crucial basic understanding. So that's the one that I lingered on and I used some time of my talk today. The stochastic SIR models, when you run virtual world, as in the Imperial College, they still provide a mechanistic explanation of what could be happening. And actually, ultimately, perhaps because of this mechanistic explanation, they may be well suited to try to understand what current and future non-pharmaceutical interventions what impact they may have. On the other hand, perhaps if you want to do direct prediction of what will happen tomorrow, maybe you're better off doing direct data fitting without having to go through the process of using the data to estimate the parameters, and then using the parameters to estimate the outcome of the mechanistic model. So in summary, as you have seen by now, in all of this model, it's very important to use data to tune the parameters, to calibrate the model. And in fact, that's precisely the topic of the next webinar that will be given by Yufang and Ambuj next week. It's 1:50. Allow me to use a couple of minutes to conclude this talk. So I have some comments. So I was asked to deliver this content, and I hope I was able to give you some guidelines on how to understand and how to compare these models. At the same time, the ground under us is shifting very rapidly. While a month ago we were very concerned with convincing everybody of the importance of imposing social distancing, now we are already discussing when can we remove that. Let me try to comment on this all of these social strategies that we're adopting. So, and let me try to do that in the context of the model I've shown to you earlier. The reproduction number, which we want to be as small as possible, is composed of how many contacts per day, and what's the transmission, and finally, how many infective days there are. When we are asked to wash hands and wear a mask, that ultimately is having a direct impact in decreasing the infection transmission beta T. So this number here will decrease. Pardon me, I think I made a mistake let me say it again. My phone rang because my time is up and I got distracted. So when we wash hands and wear masks, this will decrease the transmission rate, which means that it will have it will decrease that number, the transmission rate. If we practice social distancing and travel restrictions, that will decrease the contact rates, and therefore this will decrease the number of contacts per day. If we were able to implement, when we do testing, and that leads to quarantine for people that are turned out to test positive, this decreased the number of infective days that these individuals are in our community unwillingly. Finally, if we were able to perform contact tracing and then isolate individuals who turn out to be positive, that would also have an impact on infective days. As you see, all of these non-pharmaceutical interventions have a direct beneficial impact on the reproduction number. So the question I would like to conclude my talk with today has to do with our home institution. So can we use these models? Can we use all of the understanding we collected last week during the webinar by Dr. Gonzalez and Fitzgibbons? Can we use data-driven models to answer the following questions? What do we have to do in order to safely reopen UC Santa Barbara? What models, what data would we need? Would it be, imagine students were to in fact be willing to consent. What strategies should we implement in terms of testing, contact tracing, and other measures? And what would a comprehensive approach at the university level entail, including both digital and campus physical infrastructure? With that, I would like to conclude and thank you all for your attention, and I would be delighted to take any questions you may have. Thank you.
Thank you. Thank you, Francesco. We have some questions from the audience, and let me start with the first one. Why does the growth follow an exponential pattern and not a linear pattern? So I'm assuming this is about the SIR model. Why does the growth of infected not follow a linear, but follows an exponential pattern?
It's actually because of this nonlinearity that was discovered so early on. So in other words, in a linear growth, you would have that the rate of change x dot would be constant. But unfortunately here, the linear growth, the rate of change is proportional to the value itself. So another way to think about it is that it is x dot over x, which is constant for small s, when let's say s is approximately 1, let's say at the beginning of the epidemic. And so if it's x dot over x that it's constant, you see if that constant, it's, let's say, the number 5. So if you have, or 0 point, if you have 5%. So if you have 100 individuals, then tomorrow you will have 105. But if you have 1 million individuals, then tomorrow you will have 1,050,000. And so that's why the growth is exponential. So on a plot, a linear growth would go like this, but instead, unfortunately, we're observing something like that. Now, as I was saying, these are in percentages. So up there is the number 100%. So this curve must flatten out, but must flatten out and then must drop. And this is the point where the reproduction number becomes 1. This is the point where the community builds this terrible word, which is herd immunity. So it's a terrible word. It's mathematically extremely well posed, so it should not be given a terrible interpretation. But in any case, the reality is that you certainly do not want to reach that level of immunity at this moment in time.
Okay, thank you. The next question comes from Yushan Wang. How are interventions added? Since you don't know the underlying dynamics, how do you decide when to intervene, where to intervene? Do you use causal knowledge somehow in terms of deciding that?
This is the billion or $1 trillion question. So I read the Imperial College model and the report, and you will see that they simply raise the red flag by ultimately saying, we don't really know whether, the precise numerical impact of each single possible NPI, but at this moment in time, we should implement many, if not all of them, in order to stop the epidemic on its tracks. And there is empirical evidence that, of course, in fact, if you do practice these interventions rigorously, it literally stops the number of infected from growing completely. The challenge, and I hope to learn more myself about it, is in trying to build causal quantitative models that can make rigorous predictions so that we can, relax some of the most burdensome interventions such as social distancing. For example, contact tracing and extensive, which builds on extensive testing, would have really tremendous potential to stop the epidemic, even allowing people to live a normal life and go to their jobs.
Okay, one last question. What is the most accurate model, and what timeline does it reveal for Santa Barbara with regard to ending social distancing, quarantining, and other NPIs?
That's a tough question. I haven't seen, of course, I don't have access to direct models by Imperial College or by the IHME in order to calibrate those models on the parameter of Santa Barbara County. As I was showing earlier, the IHME from Washington, Dr. Murray, kindly provides estimates for the entire state of California. Those estimates are based on assumptions such as that the NPIs would continue to be in place. I think pretty soon we will see various entities offering predictions once the NPIs are removed.
There is one last, So one last question. What is the usefulness of these models if most of the assumptions are made on shaky grounds in terms of how useful will they be for informing policy if the models are based on shaky grounds?
That's a great question. And the answer is, this is the best that science can provide. Think of mathematics as a black box. You put in data and estimates as accurate as they come, and this black box will provide exact predictions based on that. So in 1760, you should have been inoculated based on the prevailing knowledge. You may complain that this is a definitely undesirable situation, and I will tell you that unfortunately that's the way in which we all live our life on any given day, in any given regard. You have to make the best predictions you can, and then understand that the situation on the ground may be changing and be ready to adapt.
Thank you. The clock says 2 o'clock. Thank you very much for a wonderful talk. Thank you.
Thank you all.